Good, let's see, morning, afternoon to everybody. This is Dana Mitchell. I'm one of the account managers with Mountain Pacific, and I support the homes in Alaska and Hawaii. So I have such a great couple of states to work with, and I'm gonna get us kicked off here. We're so glad you could make it for, what is this, our third? It's worth a shot. Go ahead and advance the slides there, Mary. So just a couple of housekeeping items. If you have anything you would like to see us cover for either the webinar portion or the clinician office hours, or you have a need that we can meet for you next week or one of our sessions after, please throw that into the chat so we can address it for you. And we're meeting every Wednesday through April 13th. So we've got a good chunk of time to get through any ideas or needs that you may have. All right, next slide. So speaking of, this is our question from last session, and a question that we've been hearing quite a bit over the last week or two. I'm going to go ahead and share my screen because it's easier it's going to be easier with a visual, I believe. All right, so can you see that now? See my screen with the grid?
We can see it.
Yes, we can see it.
Okay, great. So the question was really about entering into NHSN. What healthcare workers are you reporting when? And so I stopped sharing the actual question, but what I'm going to do is kind of roll through this here. So I'm looking really at the headers. So when you're reporting the booster shot, first you've got to report the number of your healthcare workers that were eligible to have worked at your facility for at least one day during the week of data collection. I think most of us have got a pretty decent handle on that. Then number two is your cumulative number of all of your folks in this question who had received a COVID vaccine at this facility or anywhere. And Tom talked about this a little bit last week. So it's a cumulative number of anyone who's received a vaccine anywhere. Then you're hopping down to number three, it's the cumulative number of healthcare workers out of all of these folks who are eligible to work who had some other condition listed there. Then where the question comes in is your cumulative number of healthcare workers out of these folks, so all the ones who have received a vaccine, who are eligible to receive an additional dose or a booster vaccine. So that's it, that's anybody who had been eligible to receive one. And then this is your cumulative number of people in this question. So all of your eligible healthcare workers who have received an additional dose or booster COVID-19 at this facility or elsewhere. So the questions are really building one upon the other and their cumulative numbers. So you're really counting everybody in that facility every week that meets any of these criteria. So I thought that might be easier to work through this. This you can find on the CDC website. I think I've got the link to it at the end of the slides. So you can always refer back to this as if that's helpful when you're doing your data collection or when you're entering your data into NHSN. So hopefully that answered that. And now I got to figure out how to stop sharing. There we go. Any questions around that?
Yes, I do.
Go for it.
So when you do the number 4, who's eligible for a booster vaccination, you put that number in. But then once you go to number 5, and you want to put in everybody who has received a booster, you can't put any more than what you did for number 4. So let's say,
oh, sorry, go ahead.
Yeah, so let's say like everybody received a booster in your facility, but 4 people. So you put 4 down for number 4. You can't put, let's say 20 for number 5. It won't let you.
Right. So that's where the cumulative means. And Tom might be able to chime in on this. So your cumulative number means you're counting everybody. So you may count somebody multiple weeks. So you're counting everybody in your facility who had been or would be eligible for that second dose or a booster. And that includes the folks who have already received it somewhere else. So then you've got who had received, then question 5 is of all that, all the folks that are eligible, who had received it. So in question number 4, you shouldn't have folks who are more, you shouldn't have more vaccines than people who are eligible. And maybe Tom can help me explain it a little bit more clearly, but 5 should be a subset of 4.
Yeah, I think you hit it, Dana. Always remember that you're counting cumulatively, and as Dana said, you might be counting the same people week after week, depending on how long they're in your home. But if you take account of all the people that are in your home for at least one day that week, in the case of residents, then you should always, you should always have a bigger number to go from. So that question 5 is, as Dana just said, would be a subset of whatever you answered in question 4. And question 4 is kind of a subset of whatever you answered from question 2.
And it's a weird way for them to do it, because your inclination is to say, to say these are the number of people I gave boosters to, but they're looking kind of rolling every week. What are the totals in the facility? Yeah, thanks, Lori. It's remember, it's only looking for those for that week of data collection. Yep. You roll off the folks who don't work in the LTC anymore, and there shouldn't be more people needing boosted than are eligible to work. That's what we mentioned.
And then also,
oh, go ahead.
It's also not just the new people that week that got the vaccine, such as the booster.
Yep.
It's anybody in there that you have, that they have a record of ever receiving that, is counted in that.
Dana, did you see the question above that regarding?
Yeah, I was going to actually ask Tom to address that one. I think he's more familiar with how that CSV form works. Tom, the question is, can we talk about the CSV and how it's directly uploaded, and is it different than the data collection form? And I do know it's different than the data collection form, but beyond that,
yes, it is different than the data collection form. The data collection form is what Dana just shared her screen a few minutes ago. That is that form. The CSV file actually looks like an Excel spreadsheet, and they have NHSN has populated the top row with.
I can share again if you like.
You need to answer for. And so you download the CSV to your computer, and then you enter your numbers into that CSV form. And what you're looking at here is a tracking tool. This is not.
Oh, that's not it.
No, this is a tracking tool. If you want to go ahead with your presentation, Dana, I can call up. Oh, here we go. Let's see, there should be a.
There we go.
There you go, CSV file template. Yes, thank you.
So now I'm going to actually turn it over to Kyla, who's going to start us off.
Thanks, Dana. I noticed this slide got put in the wrong order, so I'm just going to speak to it, and then I'll actually have a more detailed map of each of our states moving forward in the presentation. So this is basically just a vaccine hesitancy map, and that's what I'm going to be talking about today. As you can see, our states are in the higher percentage of vaccine hesitant, and I do have a map with Alaska and Hawaii, so folks that are in those states, don't worry, I didn't leave you out. But we can go to the next slide, please. Oh, so here's Alaska. As promised, we're in the highest, a lot of our regions are in this high 25 to 29% vaccine hesitant area. And I think the next one should be Hawaii. Yes, and they are, their vaccine hesitancy rate is a little bit lower. So you folks in Hawaii are doing a great job. but still there's work to be done as far as getting folks to accept the vaccine. And I'm going to talk about a few of those techniques and some resources today. Next slide, please. Oh, this is just kind of like a zoom in of our states, Montana, Wyoming, and as you can see, we're really all blue. Next slide, please. So just a couple quick definitions. So when I was trying to look for misinformation resources that are kind of fueling some of the hesitancy, I realized that there's a difference between misinformation and disinformation. So one of them is misinformation is actually if you're spreading information, but you don't know that you're spreading information that isn't accurate. And disinformation is actually doing it in kind of a, as the CDC says, with malicious intent. So it's kind of a more of a deliberate act versus misinformation is just maybe you don't have the right information and you're spreading it, but you don't realize that the information you have isn't accurate. Next slide, please. So I saw this study last week that came out. It's actually a JAMA Open article, but it looks at misinformation and folks with depression. Really, really interesting because we're talking right now a lot about depression and increased rates of depression because of the pandemic. But what this study actually found, and this was in 15,000 US adults, is that if you had moderate or greater major depressive symptoms, you were more likely to endorse false statements about COVID vaccines. So our patient population that has depressive symptoms is more susceptible to being in this group, which I thought was really interesting. Next slide, please. And then this was also another survey. This was done in Alaska, and it was done in 114 remote Alaskan communities. And it was a survey that they did before, so when the pandemic began, but before the vaccine was out. And then they repeated it in wave 2 and wave 3. And basically what they found was that folks were they were getting vaccinated at a high rate in these communities, but they still had misconceptions. And I just posted the chart from wave 3. There's wave 1 and 2 information as well, but I thought it was really interesting. They asked true and false questions of folks. And you see the answer to number 1, COVID vaccine is not recommended if you're young and healthy. And 82% of the people that responded to this survey got that answer incorrect. So that just seems, I never would have expected that. So it's just to say that we really do have a lot of work to do to get people educated. And then you see those other questions too, a little bit lower percentage of folks getting an incorrect answer, but just something to think about when you're talking to patients. Next slide, please. So I posted a lot of resources for you today. These are 2 really good campaigns that I ran across. One of them is put on by the Ad Council, the one on the right, and it's more focused on rural communities. So it's really nice that that's applicable to a lot of the communities that you folks work in. But they have a multitude of resources. They have videos, flyers, social media resources, communications resources for folks if you're wanting to do a campaign in your own location or at your own facility. There's a lot of good resources. So links to both of those. And as you see, the picture on the right and is a nice visual, I would say, for some of our rural communities. And then I really liked their slogans on these. So we can do this and it's up to you. Really kind of focusing on the patient and that this is their choice. Next slide, please. So I actually took these messaging do's and don'ts from one of the flyers that was on that one of those previous campaigns. And really, just how do we talk to patients? We want to make sure we acknowledge their concerns first and foremost, and let them know that it's normal to have questions. We want to appeal with facts. So really giving patients transparent answers, addressing safety concerns that they might have, and just really giving them the information of what we're seeing out there in the real world with folks that are vaccinated and how they are faring better than those that are not, as far as severe disease. We want to acknowledge that it's their personal decision. It's up to you, just like their campaign states. And emphasize, folks in the community that might be more at risk of having detrimental effects of COVID. So, not just thinking about yourself, but thinking about others. The don'ts are kind of self-explanatory, but really some of these things don't help people if they're already in this state of kind of wavering on what they're going to do. So don't incite negativity and fear. Don't just say it's the right thing to do. Don't overpromise. So I know early on in the pandemic, I think maybe we did overpromise because we thought, oh, these vaccines are 95% effective, 94% effective. And, now we're seeing that they are that effective still in preventing severe disease and hospitalizations, but maybe we didn't communicate that was our overall goal as well as we could have. And saying this is how we get back to normal. I don't think there's going to be a normal again. It's going to be a new normal. And so just making sure that we acknowledge that for folks as they continue to live with COVID. And then my last slide has resources. There's a training module that I thought was good. And then there's also this quiz that you can take that kind of helps you know where you're at in providing good information to patients that I would encourage you to take. And then the links to the other two campaigns I mentioned, and then some patient handouts and some information on healthcare professionals and how you can also continue to have that conversation with colleagues that may be a little bit more hesitant to get vaccinated. And I would like to share one more thing, Mary, if I could share my screen. I also ran across this training, and it's actually in Alaska, but I asked the folks that are doing it there at UAA if I could share this in a regional capacity. And they said, yes, share it widely. So if anyone's interested, there's a provider course and a community course on training to improve vaccine confidence. And it says Alaska communities, but obviously this is going to be applicable to any kind of a rural community. So I'll put those links in the chat as well. And that's all I have. Questions?
Awesome. That course looks great, Kyla. Good find.
Yeah, I'll put this in the chat. Thanks, guys.
All right, Mary, if you want to go ahead and hit mine up. I thought because of some of the other questions that we've been getting that I would kind of pick apart the latest QSO memo, the 2207, which is the interim guidance that came out whenever that one came out last month, January, and look at the long-term care section, the attachment A. So Mary, are you going to share, or do you want me to? Thank you. All right, so the first thing I thought I would just hit on the pieces that we're really getting questions about, and understandably so. This language is interesting. I thought first, I would hit on what is the definition of staff. So this is for the vaccine mandate. And reading through all of the verbiage in here, for me, it's easier maybe to define the people who are not staff. So who are not subject to that mandate. So they're folks who are exclusively offsite, even if they're employed by you, if they're doing their telehealth, telemedicine exclusively offsite, the requirement doesn't apply. Those who provide support services exclusively offsite, and really anyone who doesn't come in touch with residents or any other staff. So the mandate doesn't apply to them. Now, if your facility decides that you're going to have policies maybe that apply to your staff who work offsite, then that's up to the facility, but the mandate doesn't apply to them. And I don't know if folks were on the stakeholder call that was right before this, but I thought that they did a pretty decent job of explaining that they really can't give a list of people who it applies to. I mean, that, you know, you could have thousands of different types of people, I suppose, that come through your doors over the course of a few years. What he said is really think about what someone is doing within the facility as part of your risk assessment. And we'll talk a little bit about that. If they're not going to come into contact with staff or residents, then they wouldn't fall under that mandate. But you're probably going to run into situations where you're going to have to do an evaluation on a case-by-case basis to determine, you know, where is this person going to go? Are we going to want to make sure that they're vaccinated or not? Next slide, please. All right, so when you break down this attachment, that whole first page, page and a half is kind of a lot of gobbledygook, but it really boils down to they're looking at the policies they want you to have in place and then the documentation they want you to have in place. So the policies that they're looking for is your process to ensure that staff, except for those who are going to be exempt, receive their vaccinations for COVID. They're looking for first, second, and booster. A process to ensure that you've got additional precautions in place for staff who aren't vaccinated, and they provide a few examples, not an exclusive list, but some examples are where do you assign those folks, the source control that you're going to use, and potentially even N95 and weekly testing. They want to hear your contingency plans for those not fully vaccinated, which that rolls up into what you're going to do for staff who aren't. Or how are you going to get them vaccinated? And they want to know that you've got a process in place for folks to request an exemption. And then really you've got to document all those things. So they really go all hand in hand. So you have to have your process for ensuring vaccination. And then you also have to be able to track and document vaccination status for all of your staff. Same for the delayed vaccination. If you've got staff who are not fully vaccinated because they're delayed for whatever reason, you have to be able to track and document that, and then your contingency plan kicks in for getting them vaccinated. And you've got to be able to track and document your exemptions and all that related information. He mentioned on the call today that you do not have to keep all that documentation on site, but you are going to have to be able to provide it, and they are going to expect you to know what the status of your staff is. Next slide. All right, and we've gone through this before. I think most folks don't hear a lot of questions on this, but I thought it was important to touch on that what are your clinical exemptions going to be? So that's a pretty strict definition. So any clinical exemption has to include this list of items. You've got to have documentation from a licensed practitioner. It can't be the person requesting the exemption, so your doctors can't request an exemption for themselves. It has to be signed and dated by that practitioner, and they've got to be acting within their own scope of practice. It's got to be very specific about which vaccine is contraindicated for this person. And it's got to be able to explain why, and it must be clinical reasons why it's contraindicated. And then they got to include a statement recommending exemption based on the clinical contraindications that they documented. Next slide, please. So what is a contraindication, a medical contraindication? So according to the CDC, if your staff members had a severe allergic reaction like anaphylaxis to a prior dose or component of the vaccine, or if they have a reaction of any severity within 4 hours of exposure to a previous dose or a component, or a diagnosed allergy to a previous dose or component, then they are exempted. I don't know how you would know about the component part. I might ask Kyla about that. But that's the definition per the CDC. And then for religious exemptions, they refer you to the Equal Employment Opportunity Commission's compliance manual on religious discriminations. So when surveyors come in, they're not going to evaluate your religious exemptions. They just want to know that you've got a mechanism in place to request and grant them, and that you have those processes documented. Next slide. So contingency plans are actions you're going to take that for staff who are unwilling to be vaccinated and who do not qualify for an exemption, as well as those with an exemption and those that are delayed. Your plan can include that you impose a deadline on when you expect those folks to receive your vaccine. And what are you going to do if that deadline's not met? These are the two bullets were actually called out in that attachment, that the actions can include actively seeking replacement staff and using temporary vaccinated staff until permanent replacements are found. I think it'll be interesting going forward to hear what processes people are putting in place for their contingency plans, and we'll certainly keep our ear to the ground about that. Next slide, please. All right, so I thought it was very important for us to really understand what compliance and non-compliance looked like. So 30 days and 60 days refers to the date from the issuance of the memo, and your date's going to be slightly different based on whether you were part of the injunction or not, whether your state was. So I think Hawaii is going to be the one that's going to be coming up soonest, and then the other 3 states will be are a little bit delayed. But what they're looking for on both your 30 and your 60 days is that you've got all those policies and procedures developed and implemented. And at 30 days, they want to know these items on the left side, that 100% of staff have either received a dose or have a pending request for a dose, or they have an exemption, or they have a temporary delay. And then on the other, so that could be from having COVID, I think I had that on another slide, having COVID, having monoclonal antibody therapy, could be delays, reasons for delay. And then at 60 days, they're looking really at the same thing. They've received the necessary doses to complete a series. So that's really the only difference, is that the 30 days, they better have had one, and the other, they should have had both doses or have an exemption or a temporary delay. Next slide. So this is how they're going to evaluate for non-compliance. Again, at the 30-day mark on the 60-day mark. So you're non-compliant if you've got less than 100% of staff that have received at least 1 dose or have an exemption or delay. You'll get a notice of non-compliance, and then they have a couple of little caveats. So at the 30-day mark, if you're over 80%, but less than 100% of staff that have received at least 1 dose or have an exemption or delay, and you have a plan to achieve your 100% vaccination rate within 60 days, they're not going to subject you to any kind of enforcement. At 60 days, that range goes up to between 90 and 100%. And you must have a plan to achieve 100% within 30 days. If you're outside of these parameters, the 80 to 100% at 30 days or the 90 to 100% at 60, you might be subject to enforcement actions depending on how severe your deficiency is and what type of facility you are. Next slide. All right, so let's click on this image here, if you don't mind, Mary. So we can see that a little better. That just the link, yeah. Thank you. So this is the, I think it's the last page in that. We're going to go to page 14, which is the last page in this document. If we could zoom in on that a little bit. So this is your scope and severity grid for compliance to the vaccine mandate. Thank you so much, Mary. And so it describes, I'm not going to go through the whole thing, but we do have the link to this document. Like I say, it's the very last page there that's going to describe what your scope and severity is. And so help you determine when you may be subject to enforcement action. Thanks, Mary. We can go back to the PowerPoint. All right, and then I think the next slide is my references. So it's got this QSO that all this information is pulled out of. I went ahead and gave you the link to the guidance on religious discrimination, the CDC clinical considerations for the vaccine, and the CDC COVID infection control recommendations. Whew, we made it only just a couple minutes over. Does anybody have any questions? All right, well, we're going to take down to cover the CSV uploads for sure next, well, I shouldn't say for sure. We believe we'll cover them next week. And if you have any other concerns that you would like us to address, please don't hesitate to send to them. The links will be available and the slides. Yes, ma'am.
This is Deb from Newcastle. I do have a quick question.
Hi, sure.
When you talk about the 30 days and the 60 days, when on the 60 days you say the necessary doses, is that the 2 doses or does that include the booster?
That it is, let me see what exactly their language is. I think it's both. But let me just double check. Within 60 days. Okay. 100% have received the necessary dose to complete the vaccine series. So that's 1 dose of the single dose or all doses of the 2-dose series.
Okay.
Yep.
So it could be the 2-dose series, for example, the Moderna, and they don't have a booster, that would be considered the doses.
Compliant. Yep.
Compliant. Okay.
Yep.
That answers my question.
Sorry for that clarity.
No,
I
that's
mentioned a
okay.
risk assessment. Yeah, booster's not mandatory. Thanks. I did not mention the risk assessment again. I will make sure we send this out. This is a tough one. So the risk assessment I was talking about, we don't necessarily, I've got a tool that could be helpful. It goes back to sitting down and considering what a person who's coming into your building is going to be doing when they're there. And then whether or not you need to track their vaccination status or not. Because they can't give you a comprehensive list of people who would fall under the mandate, you've got to determine for yourself, are they going to be in a patient care area? Are they going to be interacting with staff or residents? The amount of time they might be hanging around your facility before, and then determine based on that, whether you're going to include them in your tracking or not. Unfortunately, they haven't provided us with any. I wish we had some sort of like a little device you could enter in and it would pop out an answer for us. But those weird, like we had a question, I think, about construction workers, and that's, you know, if they're going to be around patients or residents, then that may be somebody you want to ask vaccine status for and track them. But again, it's going to be dependent on your facility and your assessment of the rest of the folks in your facility.
This is Jill, and we do have on our agenda for an upcoming future series a presentation on risk assessment tools. It's kind of a scenario-based tool that we've discovered, and so coming soon to a computer screen near you. Just watch for that, and we'll send that out in the announcement. Usually the Monday or Tuesday before the Wednesday webinar, we include the topics of the upcoming webinar, so that's coming soon.
All right, guys, thanks for hanging out with us a few extra minutes. Hope y'all have a great day and we will talk to you next week.